Well, welcome to this video, and I want to talk about the possible longer term complications of COVID-19, the so-called sequelae, the sort of sequelae, the things that can come after the disease. Now, if this video is not for you, I'll just give you a brief bottom line. There's increasing evidence that patients that have recovered from COVID-19, perhaps mostly severe cases of COVID-19, but increasingly some evidence that even people that have had milder COVID-19 can be left with some residual cardiac problems afterwards, some heart problems. Now, we're going to need a lot more data on this before we can be definitive, but it looks like there's going to be some proportion of people who've recovered from COVID-19 who might be left with some residual heart damage. We hope it's a very small amount, but that's currently unclear. So this paper's to discuss that. So if you want to skip this, then that's fine. But if you want the detail on that, it is something that's concerning me. So basically, you have an acute illness and then you recover, unless, of course, you die. We know that the acute illness in COVID-19 can last for several weeks. Some people are ill for quite some period of time. And then you can be really quite tired for some weeks or even a few months after that. That's kind of a convalescent period. And people can feel undue fatigue for some time, but they normally pick up and get better. But sequelae are things that can be things that will generate long-term clinical features because of potential permanent damage that's being caused by the virus or indeed the body's inflammatory response to the virus. So there's two things that can cause the damage: the direct viral damage, the virus in the tissues, or the body's immunological response to the presence of the virus, which can cause things like inflammatory changes. So let's dive into that now. So this is from Journal of the American Medical Association, 27th of July, Coronavirus Disease 2019, and the heart. Is heart failure the next chapter? Are we going to be left with people that have this as a chronic long-term problem? Now, quick background here: increased risk of for morbidity and mortality complications in COVID-19. So morbid is to do with disease. Mortal, of course, is death. So in other words, with these features here, we've known for a long time now that people with pre-existing cardiovascular disease are more prone to getting more serious COVID-19 disease, more prone to being hospitalised, and more prone to dying. It's one of the classic comorbidities that we now understand to some extent. So pre-existing cardiac disease will make COVID-19 potentially more serious, greater chance of fatality. We know that. As will high blood pressure. Hyper is high, tension is the pressure, hypertension. So hypertension is a risk factor. Coronary artery disease. Now the coronary arteries, again, coronary derives from the word crown. So if you turn a heart upside down and you look at, that's the heart there, and you turn it upside down and you look at the coronary arteries, they've got this crown-like structure that goes over the surface of the heart. That's why they're called the coronary arteries, the crown-like arteries. Just the same, ironically enough, as COVID-19 or coronavirus is the crown-appearing virus. So coronary artery disease of the arteries. And these are the coronary arteries that supply the heart muscle with blood, and the heart muscle is the myocardium. The essential contractile muscle in the heart is supplied with all its blood from the coronary arteries. So the heart does not get its blood directly from the blood that's flowing through the heart. It gets it via these specialised coronary arteries. And the coronary arteries are the first two arteries, the right and the left coronary artery, the very first arteries that leave the aorta. And the aorta is the main blood vessel that leaves the left side of the heart, that leaves the left ventricle to take blood to all of the systemic circulatory system. Patients with heart failure are also at increased risk. Heart failure is where the function of the heart, the ability of the heart to contract, is inadequate to pump blood and oxygen into the tissues of the body to meet the metabolic demands of the body. So heart failure is basically pump failure. Tends to develop slowly, tends to be a chronic condition. Not always. So we know that, but the question is now, can COVID-19 cause heart disease? So we know that heart disease increases the risk for severe COVID-19. The question is, can COVID-19 itself cause complications to the heart? And unfortunately, the answer to this is emerging more strongly now to be yes. Now, this information in the Journal of the American Medical Association comes from post-mortem studies. So post is after, mortem, death, of course. In the States, they tend to call them autopsies. So in the UK, we call them post-mortems. In the States, they call them autopsies. It's exactly the same thing. So 39 autopsies on patients that died from COVID-19 pneumonia. Now, this paper, and do look it up for yourself, it's that top one there. These, of course, will be in the description. It's written in medical terms, so let's try and kind of make sense of it. Now, the first thing they're saying is that histopathic evaluation did not meet criteria seen in myocarditis. Right, histio is the tissues, that means the heart muscle tissue, and histopathology is the study of disease at the level of the tissues. Now, there is a disease called myocarditis. Now, itis, whenever you see itis on the end of a word, that means inflammation of. So myocarditis clearly is inflammation of the myocardium, the contractile muscle of the heart. Now, so there are some viral myocarditises. So the person can get a viral infection, the virus can go to the heart muscle and can damage the heart muscle, sometimes really quite severely. And in fact, when I worked on coronary care, the most common indication for heart transplantation was viral myocarditis in younger people, where the virus can actually damage the myocardium irreversibly. Now, so what they're saying is when you look at the cells in the microscope, that's the histopathologic evaluation, did not meet criteria seen in acute myocarditis. It means it wasn't as bad as that. So we're not talking from this study about an actual frank myocarditis that we've been used to that can virtually eradicate the myocardium. So that's kind of good news. It's not looking as bad as that. But there is evidence of the virus present in the heart in 24 of 39 patients. So remember, these are patients that died of COVID-19 pneumonia. They died of pneumonia, but when they examined the hearts of these patients, despite the cause of death being in the lungs, 24 out of 39 had evidence of the virus present in the heart, despite them dying of pneumonia. And of these 24, 16 patients had a high viral load. In other words, 16, so it's 16 out of 39 patients, 39 patients that died, 16 of those patients had a large amount of COVID-19 virus in their hearts. They had a large viral load. So clearly what this means is the virus had migrated from the lungs to the heart. The virus was actually present in the heart. And evidence of viral replication was also noted. In other words, they could see cells in the heart where the virus was actively replicating, where the virus was actively reproducing at the time that these patients died. Ongoing viral replication. So the virus hadn't just gone from the lungs to the heart. Well, it had. The virus had gone from the lungs to the heart, but once it was in the heart, the virus was invading cells in the heart and carrying on multiplying. There was viral multiplication. viral reproduction in the heart. And also, there were activation of genes in the heart muscle that promote inflammation. So what seems to have happened here is, via a mechanism that's not yet clear, the virus had actually stimulated the activity of genes in the heart which promote inflammation. So genes can be upregulated, meaning they become more active, or they can become downregulated, meaning they become less active. And in this case, as a result of the infection, 6 of these genes that control inflammation have been upregulated, meaning there was more inflammatory changes going on. And inflammation has the potential to damage the heart. So this means that myocardial injury can occur by two mechanisms. Via two mechanisms. The first mechanism by which the heart muscle can be damaged is the direct presence of the virus itself and the multiplication of the virus, and the virus potentially killing myocardial cells, although thankfully it doesn't kill them like a Coxsackie virus will, for example, which absolutely devastates the heart muscle. So it can be the direct effect of the virus itself, or it can be the inflammatory changes in the heart initiated by the presence of the virus. Both of these things can potentially damage the heart. And the thing is, some tissues will recover. So if you scrape the surface of your skin, the epidermis, and you don't completely remove the epidermis, or even if you did, it can migrate in from areas of adjacent epidermis, it can completely recover and you'll be left with no scar. And it's the same with the liver. You can damage your liver quite a lot, for example, if you had a viral hepatitis, or indeed if you abused your liver with alcohol for a period of time. But after the viral hepatitis goes away in most cases, or after the person stops drinking in most cases, the liver can completely recover. Or if you cut the inside of your cheek, if you bite the inside of your cheek, it really hurts, but then a week later it's recovered. But muscle is not like that. Muscle cannot completely regenerate. The cells can't divide. It's not actively mitotic. Mitosis is this form of cell division where the cells divide and replace themselves. Heart muscle can't do that. So once it's scarred, once that muscle is damaged, if the muscle cells die, that's it. It's lost. It's not replaced by adjacent healthy muscles. It's lost. This is why there can be sequelae, because once the heart muscle has been damaged, it can't recover, unfortunately. The nervous system is a bit like this as well. If someone damages their spinal cord, then they can be paralysed for the rest of their lives because the nervous tissue doesn't recover. And so muscle tissue and nerve tissue doesn't recover. So the damage can be permanent, unfortunately. So 100 recovering patients were examined in this study. Now, some of these patients were recovering at hospital and some were recovering at home. So this is the second part of the study now. So the first part was the post-mortem studies, 39 patients that died. And the second part was 100 patients that recovered. And they were evaluated for an average of 71 days after confirmed diagnosis, so quite some time. Now, they did find at periods of time after this detectable troponin. Now, troponin, what troponin is troponin is a chemical inside heart muscle cells. And it's normally located in the heart muscle cells like this pen, and it can't escape. But then if these heart muscle cells die and they break up, then the troponins can get out. So normally the intact cells, the living cells, keep the troponins in. But if that cell dies, the cell breaks up, the troponins get out. So that means if you're detecting troponins in the blood, that is an indication of myocardial cell death, damage to the heart muscle. So that was concerning, that troponins are detected sometimes quite a long time after, meaning there could be some ongoing cardiac damage. And reduced left ventricular ejection fraction. Now, the trouble is with these medical papers is they're not accessible because they use big words. But what this means is that the ventricle is the pumping chamber in the heart. So it fills up with blood, then it pumps, and it pumps, the left ventricle pumps blood out of the aorta into the systemic circulation all around the body. So it's a contractile muscle. Now when it contracts, it's supposed to pump out at least 55% of the blood that's in it. So it doesn't fully, so it more contracts like this. Then it feels again, pump, pump, like pumps the blood out. 55% is supposed to be pumped out per time. But if you've got a reduced left ventricular ejection fraction, that means instead of pumping out 55%, it's probably only pumping out 45%. In other words, the left ventricle is not pumping as well as it used to. That's what it means. This is pump failure, to put it in simple terms. That it's not pumping out the blood as well as it did. So that can be reduced. As well as that, ischemia, leave out the A in the States. Ischemia is a reduced blood supply to the heart muscle. So normally we have the coronary arteries here that divide into smaller coronary arteries. And these coronary arteries take blood into a particular area of the myocardium that they are responsible for perfusing. So that branch of artery normally carries blood out into that area of myocardium. It's perfusing that area of myocardium, taking oxygen and nutrients. And this branch of the coronary artery here will perfuse this other part of the myocardium here. Now in ischemia, the amount of blood getting through to an area of the myocardium is reduced. That's what ischemia means. There is myocardial ischemia. And if there's myocardial ischemia, that means there's not enough oxygen getting through. And if there's not enough oxygen getting through, that means the metabolism in the heart muscle can change from aerobic and it can change to anaerobic, metabolizing without oxygen. Anaerobic metabolism causes the production of lactic acid, and it's the presence of lactic acid in the heart that causes the pain called angina pectoris. So angina is the pain caused by myocardial ischemia. So what seems to have happened in these patients with COVID-19 is perhaps there's been inflammation of the lining of these coronary arteries, and that's damaged them and means that they can no longer transmit as much blood, potentially narrowed them so they're not transmitting as much blood through to the myocardium. So these patients, some of them suffered from ischemia, and some of them had pericardial involvement. Now peri means round about the outside. So if we imagine that is the heart there like that, that's the heart, and round about the heart there is another layer of tough fibrous tissue round about the heart like that protects the heart and stops it from overexpanding. And that layer around about the heart, surrounding the heart, is the pericardium. The pericardium, the area surrounding the heart. And of course the heart muscle is the inside layer. That's the thick layer of heart muscle like that. That's the myocardium. So the myocardium is the muscle. And there's also a layer of thin vascular lining tissue on the inside of the heart. And that inside layer is called the endocardium. So I used to force all my students to learn that: myocardium, pericardium, endocardium. Anyway, so the pericardium can be involved and inflamed. And that can also affect the function of the heart because it can interfere with the expansion of the heart and cause functional difficulties in the heart. Now, cardiomyopathy and heart failure related to COVID-19 may become evident. So cardio is heart, myo is the myocardium, the muscle, and pathy is disease of. So disease of the cardiac muscle may become evident as a sequelae of COVID-19 disease, is what this paper is saying. And that has the potential to give ongoing morbidity, heart failure, and other chronic cardiovascular complications. And if you want to read it, the British Heart Foundation also describes things about this, often in much simpler language than I've managed to spit out on this video. Now, what this means is there may be some people that die of cardiac complications, but it's looking more like that the cardiac complications are less likely to cause death, although they can, because as well as causing this physical damage to the heart, they can cause disruption to the way the heart works. So normally when the heart's working, we have a P wave, then a QRS complex, and then we have a T wave, like that. P, this is classic, this is the ECG, EKG, sorry, in the States, P, Q, R, S, and T. It's the name of these waves, P, Q, R, S, T. Now, a normal heartbeat will have a P, Q, R, S, T in the right order. It will be fairly regular, and the rate will be between 60 and 100 for what we call a sinus rhythm. But if this becomes abnormal, we get what we call dysrhythmias or arrhythmias. So, for example, you can get one called atrial fibrillation, where the sort of baseline doesn't have the well-defined P wave, and you get different shaped QRS complexes like this, and they are irregular. So when you take the pulse, instead of a nice steady pulse like nice steady pulse in sinus rhythm, in atrial fibrillation it can be kind of all over the place. It can be irregular, often described as irregularly irregular. So that's another potential complication, that the normal sinus rhythm could be disrupted, giving abnormal heart rhythms. And of course, if the heart rhythm's very abnormal, we can get a condition like that. That's an emergency condition called ventricular tachycardia, and sometimes we can get one that kind of looks like this. That's a cardiac arrest rhythm called ventricular fibrillation, both of which, of course, can be rapidly fatal. So, possibility for these anatomical problems and physiological problems. Now, what we don't know is how common these will be. I think what we can say at the moment is there are going to be cardiac sequelae. This probably will increase the burden of cardiac morbidity in the population. We're hoping that the numbers are going to be very small, but as of now we don't know. But there will be some. So far, a lot of the thinking about COVID-19 has been to do with the lungs, and we know there can be pulmonary fibrosis, but now it appears there can also be longer term heart problems as well. And it's also unclear at the moment whether the probability of having cardiac sequelae is directly proportional to the severity of the disease. So it may be that people get mild respiratory disease and mild acute disease, but could be left with cardiac complications. That is not yet clear. So this could be a 0.000.0001 problem or something, fraction of a percent, or this could be a few percent of people that recover do have this long-term potential complication, and we really need to get more data on this as soon as we can. So while I'm optimistic that we can get rid of the acute disease, I think we can vaccinate it out of existence. I'm on record of saying that. I still believe that. But we could be left with patients for potentially decades to come who have some longer-term cardiac sequelae. And at the moment, we don't really know. I suspect there will be some. I'm hopeful it's not going to be too many.